going to introduce our next speaker, Dr. Riyad Al Fakih. He's a consultant hematology and transplant at King Faisal Specialist Hospital. Riyad, he's going to talk how I choose who to transplant for ALL. So welcome, Dr. Riyad.
Thank you. Which mic should I use, or you can hear me? Okay. Can we get the slides? All right. So my job is to talk to you about how I choose who to transplant in ALL. And Dr. Jabbour brainwashed you with Glina, Kona, Hypercivad. So now we're back to real life, what we do here in this country. So we'll do a quick overview about the ALL, and we'll go over the transplant indication in the era of adult type chemotherapy protocol, then in the era of pediatric type chemotherapy protocol, and later on we'll talk about transplant for Ph positive. So as you all know, ALL is a rare disease in adults, and it's the most frequent leukemia in kids, and this is why pediatricians excelled in the treatment of ALL. In adult and in pediatric, you can reach up to above 90% remission rate with any induction, actually. But the problem in adults, you have only 40% survival as compared to 80% survival in pediatrics. So basically, we're losing tons of patients after inducing remission. And thus, risk-oriented consolidation therapy is the key to improve survival in adults. So here comes the $1 million question: how to best consolidate an adult in CR1? Do we use a pediatric regimen? Do we use transplant? Or we do risk-oriented therapy based on the disease characteristics, patient characteristics, and response to therapy? And we don't have a clear answer. However, we have a lot of clues to help us. So this is a quick summary about the outcomes of patients treated on adult type chemotherapy protocols. If you start with 100 patients, 40 at best will be cured. Okay, 60 will be relapse refractory, and from these 60, you can salvage 10% at best. Okay, so you end up with 46 cured. So 46%. This is the best case scenario using an adult type chemotherapy protocol. So these back in the era of the adult type chemotherapy protocol, investigators looked back on these patients, and they identified a set of risk factors that correlate with higher risk of relapse. Okay, and these became the high risk features, or what we call now conventional risk factors, used to classify patients into high risk, low risk, and thus decide how can we consolidate these patients. And as you see in this list, CNS involvement, hypodiploidy, near triploidy, resistance of the disease, and MRD positivity by immunoglobulin, elevated white count, age, MLL, translocation 119, complex karyotype, immature phenotype, and Philadelphia positivity were these risk factors. Now, from the trials done about transplant in the era of adult type therapy protocols, okay, we have this table summarizing the major trials done. What we see in the LALA trials, the first LALA trial, they did donor, no donor. Okay, they classified patient high risk, low risk based on the conventional risk factors. So if you have a donor, okay, in the LALA 87 trials, and if you have high risk, actually any risk, okay, transplant did better, and it was statistically significant only in the high risk subgroup. So in the LALA 94, they offered transplant only for people who are high risk, and again, transplant was better than non-transplant. Okay. Now, the biggest trial in the adult type protocol is the MRC on the bottom of the table. Okay. In this trial, if you see the leukemia-free survival is double in the group who got transplanted as compared to non-transplanted. However, the TRM was very high, 35.8%, and thus there was no clear survival benefit in the high-risk group where most of the TRM happened. So basically what we can take from this table is leukemia-free survival is much better with transplant all across all trials, okay, regardless of the risk. Leukemia-free survival is better. TRM is higher, okay, with transplant. And then if the TRM is in the range of 25% and above, you lose whatever benefit you got from controlling the leukemia relapse. Okay, so you end up with non-benefit. And this is a graphical view of these trials. Okay, as you see, these are donor, no donor curves. The transplant curve, the donor curve, is always on the top. Okay. But again, when you get into TRM in the range of 25%, like in the MRC ECOG, the difference becomes much less and non-significant sometimes, okay? So you have, as of now, okay, transplant is the best treatment to control relapse, okay? However, you lose that benefit from TRM. Meta-analysis, same thing. Okay, some meta-analysis showed overall survival benefit in high risk. Some meta-analysis showed overall survival in standard risk. So did not answer the question clearly. Okay, autologous transplant in Philadelphia negative adult type ALL. As you know, there is no graft versus leukemia. There is the possibility of graft contamination. And in the MRC ECOG trial, which is the largest trial, okay, we have clear answer about that, okay? Auto transplant is not an option for Philadelphia negative ALL. So they always do worse than chemotherapy treated people. So auto, forget about it in Philadelphia negative ALL. So in summary, allo transplant in CR1 for people treated on adult type chemotherapy protocol significantly reduced the risk of relapse in standard and high risk patients. Okay, it is associated with high TRM, and the benefit of the relapse control might be negated by TRM, especially in older people. Overall survival benefit is seen in all risky group, but sometimes not statistically significant, especially if the TRM is higher than 25%. Auto is not acceptable for Philadelphia negative ALLs. Okay. Beyond CR1, the outcomes are very bad. Okay. If you look at the two first trials, okay, so the first is relapses that happened on the LALA trial, 5-year overall survival 7%, okay. If you get to transplant them, it becomes 25%. The MRC ECOG, 609 patient relapsed, 5-year overall survival, exactly the same, 7%. If you get to transplant them, you get into a range from 15 to 23%, depends on the donor. MAT versus matched sibling versus auto. So basically, in transplant, if you can, in CR2, if you can take your patient for transplant, this is where you expect the best outcome. And in the PITHEMA trial, they showed that the best overall survival post-transplant in relapse is in patients who got a long CR1 and younger than 30. So you expect these people to have the best outcomes. Now, whether this benefit is from transplant alone or from the disease characteristics and the patient tolerance, we cannot tell, okay? But essentially, if you can take your patient to transplant, you have to take them to transplant. So in the pediatric protocol, as you know, pediatric protocols are invading our practice now. So they rely more on non-myelosuppressive drugs and the less use of transplant. So, and several prospective and retrospective trials showed better outcome of pediatric protocol as compared to adult type therapy protocol. So, what's the role of transplant on this pediatric protocol? It's not very clear. However, we have some answers from the GRAL trials. So the GRAL trials are adult patient treated on pediatric type of protocol, but offered transplant based on the conventional risk factors. Okay, so the risk factors used in the adult era. So on the GRAL trials, the investigators, okay, went back to check who did benefit from transplant. So these are patients treated on pediatric protocol, but the indication for transplant was based on the conventional risk factors. And the investigators went back through these patients to see who did benefit from transplant, so that we can tell, okay, on a pediatric protocol, this is who benefit, this is who doesn't benefit from transplant. So the risk factors to allocate to transplant and high risk were the conventional risk factors, okay? And the curve are on top of each other. No benefit of transplant, okay, based on conventional risk factors. So if you use risk factors, conventional risk factors, while using a pediatric type chemotherapy protocol, there is no benefit for transplant versus non-transplant. However, when they went in back and checked the MRD positivity, it's very clear that MRD positive people on pediatric protocol will benefit from transplant. And this is one of the indications for transplant on people treated on adult type of protocol and pediatric type of protocol. So MRD positivity, definitely go for transplant. Okay. Now, the same investigators, same patients, they went in back and checked what's associated with higher risk of relapse and thus might benefit from transplant. Okay, so they went back on these patients treated on GRAL trials and checked what are the risk factors that put these patients at risk for relapse. Okay, so basically Philadelphia chromosome negative patient, ALL and CR, okay, and the primary endpoint was cumulative incidence of relapse and define the risk factors for relapse on these pediatric protocols. 423 adults qualified for the inclusion, 265 B cell, 158 T cell. Okay. So this is by MRD. The top curve is MRD positive. The lower curve is MRD 1 in 1,000 and 1 in 10,000. So obviously, if you have positive MRD, your cumulative incidence of relapse approaches 60%. And thus, these patients will benefit from transplant. If you have focal EXIF mutation, same thing. Your risk of relapse is much higher. So these are patients treated on pediatric protocol, okay, not adult protocol. So if you have MRD positive, the risk of relapse high. If you have EXIF positive, the risk of relapse high. There is one missing slide actually about the notch mutation and P10 mutation in T cell, P10 mutation associated with higher risk of relapse. And then they put them into risk. If you have any of MRD positive or these new oncogenetics positive, you are classified as high risk. If you have none of them, you're low risk, okay? And obviously, if you have both of them, you have the highest risk of relapse. And if you don't have any, it's the lowest risk of relapse. And then the top curve is patient with positive risk factors, MRD, EXIF, P10, and the lower curve is if you don't have any, okay? So the outcome, if you have any of these, is lower than the outcome if you don't. So here we ended up with what we call the modern risk factors, okay, or the risk factors associated with higher risk of relapse if you're using a pediatric type chemotherapy protocol, which are MRD more than 1 in 10,000 post-induction, translocation 411, focal EXIF mutation, and in the T cells, absence of notch, okay, a mutation, and or NKRAS mutation or P10 gene alteration. So if you have any of these are associated with higher risk of relapse, and thus transplanting these people, even if they are receiving pediatric type therapy protocol, might be better. So in conclusion, pediatric protocol seem to be more effective than adult type of protocol. However, we don't have a randomized controlled trial, okay, and we don't have a very long follow-up on the pediatric protocol. Role of transplant on this pediatric protocol need to be clarified and defined. Definitely, if the patient is MRD positive, I would go for transplant. If you have the new oncogenes that we spoke about, this might be an indication for transplant because you have a higher risk of relapse, and it's very well known. Transplant is the best modality to control relapse. And we don't know anything about Philadelphia-like people treated on these protocols. So better understanding of the value of the conventional and the new risk factors in the context of pediatric protocols is much needed. And another question is, what's the role of autologous transplant for people with negative MRD? Now we switch gear and quickly talk about Philadelphia positive. As you know from the previous talk, long-term survival around 25%, and this is very well known from large set of patients on LALA trial and MRC trial, and this is with transplant. Okay, so before TKI, 25% would survive, and most of these were transplanted. With the advent of TKI, higher remission rates were achieved, and more patients were getting into transplant and getting cured. And then the new question is using less toxic option better, like new generation TKI autologous transplant? Okay. So as of now, as we speak, allo transplant remains the standard of care in CR1 for Philadelphia positive ALL, and several reports showed that. Okay. Most of them used imatinib because that's the oldest TKI, but recently from the US intergroup published by Dr. Ravandi, it showed that if you use hypercivadasatinib, still transplant gives you better relapse-free survival and still indicated. However, this might be changing, as we'll see on the next few slides. So by incorporating MRD into the decision making in Philadelphia positive, things might change. In the pediatric group, Dr. Schultz in 2009, they published a pediatric type chemotherapy protocol with imatinib. So this is for pediatric patients, and showed that pediatric type chemotherapy plus imatinib, okay, you do not need transplant. It's better than transplant actually in pediatrics, okay. Dr. Ravandi published about the role of MRD. So they proved that if you have a major molecular remission, okay, in patient treated with TKI plus intensive chemotherapy, transplant might not be needed, okay. And the last publication is from MD Anderson as well, showed that 4-year overall survival is around 66% if you achieve complete molecular remission at 3 months. Okay, so in these scenarios, transplant might not be needed. And then the Europeans did a lot of investigation about autologous transplant in Philadelphia positive, and these trials, though the number are limited, showed that auto transplant might be equivalent to allo transplant, especially if you achieve deep remission. And most recently, actually, this is the largest trial about autologous transplant in Philadelphia positive. This was published in December 2018. So this is EBMT database analysis. They went back through the EBMT database, okay, and they collected patient in molecular remission, okay, so patient in molecular remission, and they stratified them to see what happened to the patient who got auto versus allo in complete molecular remission. Okay, so patient in first molecular CR who underwent the transplant, okay, myeloablative condition. So there were 569 patients, 67 on the autologous arm, 255 got matched sibling, 247 got matched unrelated. So the first top curve, the A curve, is the cumulative incidence of non-relapse mortality. Definitely you will get more mortality with matched unrelated or matched sibling, okay? And the lowest curve is the auto, so no non-relapse mortality, basically statistically significant. On the other hand, the relapse, so you will see more relapse with the autologous as compared to the others. But all in all, what you get is curves on top of each other, okay? Because what you lose from relapse in auto, okay, you gain with less non-relapse mortality. So what do you prefer if you have these curves? These are auto versus allo. Of course, 20% of these allo are surviving with chronic GVHD. So definitely I would choose auto and avoid GVHD. So which adult ALL patient should I offer allo in CR1? Okay, any patient with a sibling donor, if you're using adult type protocol, you're not wrong if you choose any patient on adult type chemotherapy protocol, especially if you're not monitoring MRD. So you don't know what's the MRD. I would avoid though in elderly and frail patient because I would get more TRM and lose the leukemia-free survival I get from transplant, I would reserve alternate donor and MUD for patient in relapsed refractory disease. So if I have a matched sibling donor, a patient in very good shape, okay, I would proceed on patient treated on adult type chemotherapy protocol without MRD data, okay? And on patient receiving pediatric type therapy, if I have persistent MRD, definitely. If I have any of the modern oncogenes, if I have Philadelphia-like, and of course in the relapsed refractory setting. Now, the dilemma on how to consolidate a patient in CR1, adult patient in CR1, will continue to evolve. And this is because we have novel therapies, as you can see here. We have the Lina, ENO, UTKIs, CAR T cells. And on the other hand, the transplant is improving. If you look at the bottom line, okay, so this is EBMT collected data, about 3,000 patients collected, okay? And what they did, they went back through their database and saw what happened over the years for people transplanted for ALL and CR1. And as you see, you gain a survival of around 5%, okay, per 5 years. So each year, the transplant-related mortality is less, and you're getting into better survival, less non-relapse mortality with transplant. So basically, transplant-related mortality is becoming less, transplant is getting better, and at the same time, you have novel therapies emerging. Okay, and this is why this dilemma on how to consolidate a patient in CR1 will continue to evolve, and it's not easy to answer right now. I would like to take this opportunity to tell you about our next event, which is the annual Saudi Hematology Congress in the first March of 2019, first weekend of March 2019. So